Good afternoon, everyone. On behalf of PrepMedico and Nama Medicine, I invite you all for this first official session of PLAB training seminar. It's more than a seminar. It is something like a one-to-one interactive session where you will be participating and learning, and our faculty members will teach you. So to introduce myself, I am Manikandan Kadupel. I'm one of the consultant surgeons in the UK. And I have with me today Dr. Sibi Raj. He is a GMC registered doctor who had recently cleared his PLAB exam in his first attempt. And today's agenda would be to discuss on the history-taking sessions specific to medicine and pediatric subjects. So what we will do today is Sibi will first of all give you a very brief introduction about what you will expect in these stations and how you are expected to perform and how markings are done in this station. Following that, we will ask one by one, or whoever wants to participate, you can raise your hands and you can participate and see. Don't be shy or don't be afraid of these things. It is just a practice session just to warm you up all, just to make sure that you understand what are these exams all about. Okay, over to Dr. Sibi. And I would be very grateful if you guys can switch on your cameras, because it makes things more interactive when we see each other and do the session. Thank you, everyone, and I will hand over to Dr. Sibi.
So good afternoon, everyone. So I hope you're all doing well. So today's session is going to be about history-taking stations, specifically to medicine and pediatrics. Now, I've planned this session in a way where I'll discuss how you go about the structure of the whole station in medicine and pediatrics. And then I have got 6 mock questions where you can, come and participate. We'll put in a timer like we do in the exam. And once you perform the station, I'll discuss about what could be done better, what you did well, and what kind of things they expect in that particular station, so that you'll have a good idea about how to go about these stations. So we'll start. Once you have these stations, so the first thing you do when you enter these stations is you introduce yourself, you tell your name, you tell your GMC number, and explain who you are, as in what doctor your foundation, your doctor usually, and what setting you are in. So these are the first initial important things they look when they mark your IPS as well. So then the next question you ask is, you ask the patient what happened and why are they in the hospital today. And usually patient gives a certain symptom, or usually they generically tell that they're not well. Then you can go into why they're not well specifically. Now, empathize with the patient when a patient comes in with the complaint that you feel sorry, and you try to understand what problem they have, build a rapport with them, and make them comfortable, and explain to them that we'll try to get to the bottom of this, we'll try to find out what is bothering you, and we'll try to rectify that complaint. And and also ask when did this start, ask briefly about the complaint, don't waste too much time as well. You remember you have only 8 minutes to perform the entire station. Now coming to the structure, so based on the complaint, we have some mnemonics we can follow for easy data gathering, so that you can reach to the point where you can find the diagnosis very easily. In case of pain, we have all read it in our medical schools. It is Socrates. site, onset, character, radiation, associated symptoms or any other symptoms, time period for which they've had the symptoms, exacerbating and relieving factors, severity, and scoring. So probably, I don't know, a lot of people would have asked the scoring system in back in where they did medical school or back in their home country. Scoring is a very important part of Socrates. So whenever you have a patient coming in with pain, ask them to score the pain, and if they give you a very high scoring of pain, say 7 out of 10 or 9 out of 10, ask them if they require pain relief immediately, and tell them we'll try to arrange for it while we talk to you. So the point being, the patient is not uncomfortable to further answer all your questions, and patient is very comfortable throughout the session. So you should make sure of that when in the station by asking the scoring. So that is about presenting complaint as pain. So you have to ask all these questions and try to usually in almost all cases, in almost all stations where pain is the symptom, once you've asked these questions, usually it will lead to a diagnosis, because all the stations are designed for you to complete at 8 minutes and come up with a diagnosis or a set of differential diagnosis. So going to the next structure. So if a patient comes with a symptom other than pain, let's say, so you have a mnemonic called Audipara. So before you ask Audipara, which I'll come to in the next slide, the first thing you ask the patient is this the first time you're experiencing the symptoms? Did you have this chest pain before, or did you have this leg swelling before? Has this happened before and subsided? And is this the second time you're getting this? In a lot of cases, the patient might have experienced this, and the symptom would have subsided, and the patient is again getting a worst version of the same symptoms. A case being multiple sclerosis. So in case of multiple sclerosis, patient would have got ocular symptoms, but the ocular symptoms would have diminished over a particular period of time, and then it would have come now with a better severity. So when you ask this question first, you will pick these cues and you can come up with a diagnosis easily. Next, coming to Audipara. So other symptoms like cough, shortness of breath, this is the mnemonic we usually use. So it's again onset, it's again duration, intensity, progression, aggravating factors, relieving factors, and associated symptoms. Here you don't have scoring. Here you have pretty much everything we discuss as part of Socrates other than severity and scoring. So I hope you understood. Does anybody have doubt till this point? Yes?
No, everything is clear.
Okay, thank you. So next is patients with neurological symptoms. So this gets a little bit tricky. So when a patient comes with neurological symptoms like fit, falls, loss of consciousness, vertigo, dizziness, you have to structure it as before, during, after. So what was the patient doing before this symptom happened? So was the patient all right? Was the patient having any other symptoms like fever or flu or vomiting? Was the patient generally unwell? Now coming back to what happened during, what was the patient doing? Was there anyone close by who was looking at the episode and try to gather information as to what happened during the episode? Did they have any other symptoms? Then coming to after, did the patient again regain consciousness? Were they doing well, or was the patient taken to the hospital directly after this episode? So that is how you will divide medicine station, where you have fits, falls, vertigo, dizziness, all neurological symptoms. So yeah. Then throughout all of these stations, especially with history taking and counseling stations, a lot of patients have these questions. Questions they might have found on the internet, questions they might have thought because their neighbor had something similar. So whenever patients come with these questions, I've given them examples as MMR vaccine cause autism. Can I take this herbal medicine for this symptom or condition? So the first thing you want to ask, you shouldn't judge them badly, and you shouldn't straight away start giving them advice. No, it doesn't cause, what you read is wrong. No, don't like annihilate them. Ask them, why do they think that MMR vaccine causes autism, and why do they think this will help? So they'll have an answer which you can correct and say, okay, what you've read has been disproved, or this might not actually help, and how this might affect if they are taking this. So make sure you take patient concerns in a good way and use their words and restructure the answer when you explain all these things. So that is very important. And most of the time what happens is, when people ask these questions and you start answering, you explain these for about 1 or 2 minutes, wasting your time as well. So usually when you ask the why question and they give you an explanation, you can cut short your correction very shortly and move on to your next point. So that is why it's very important, whenever patient comes with these questions, you ask why they think so. Yes. Then once you've finished data gathering, then you have to ask questions about differential diagnosis of the same symptom. So when you have chest pain, what and all conditions will cause chest pain? You'll have tried to rule out at least 4 or 5 which are commonly seen, and you will usually get to a diagnosis within the 4 or 5. Let's say a patient comes with chest pain, you're doubting if it's MI, or if you're doubting it's pericarditis, or you're doubting it's just musculoskeletal pain. So keep some 2-3 questions for every symptoms ready, so that you can ask these questions in the DD and move on to your examination and finish your data gathering pretty briefly within the 3 minutes you have for the station. So usually, as we've discussed in our previous webinars, the history taking stations should be split into 3 + 2 + 3. So for the first 3 minutes, try to gather all the data you can about the patient, and then ask questions about differential diagnosis. Then come in the 2 minutes you have tried to examine them, and then usually in many cases you have specific tests you have where you ask them. The examiner will give you a positive result or a negative result, with which you can come to a diagnosis. So all in all, try to come with the data gathering and diagnosis within the first 5 minutes. And then the last 3 minutes, try to come up with a management plan for the diagnosis you've arrived at. Now, coming to past history, usually in the UK, a lot of people have allergies to a lot of things. So we have a mnemonic again for past history called MAFTOSA. So the medications they've been previously taking, allergies, family history of diseases, or if they have a twin who has the history of disease, or anything like that, and travel history and contact history. So something about travel history, in a lot of infectious disease cases, when you ask the patient, have you traveled to a certain country like South America or Africa where a certain disease is prevalent, like malaria or any other infection, Usually patient might tell no. But in many cases, what happens is, if you ask them, did anyone of your family travel and come from there, they would tell yes. Their son went to South Africa and he came back recently, or their daughter went to South America and she came back recently. So travel history is again a tricky one. So if they tell no, I haven't traveled anywhere, please ask if anyone in the family has traveled and come back recently. And any contact history, like in case of COVID or any flu. Occupation is again very important in case of lung diseases, where you have developed a lot of lung diseases where the patient has worked in a certain factory. Lifestyle. Now, lifestyle is diet, exercise, sleep, alcohol, smoking, and recreational drugs. So again, only ask these questions when you feel that it's related to the station you're performing in. And don't unnecessarily ask any of these things because you have to follow a certain dictum, or this, you have to complete this entire mnemonic. Please don't do that. When you have a chest pain station about chest pain, don't ask a lot about sexual history. You don't need to. There is no need for asking a certain type of history in that. So if you're asking these unnecessary questions, it will waste your time. And sometimes the patient even might ask, why are you asking this question, which might lead you to lose marks. So make up your mind when you enter a station about what kind of past history I'm going to ask, what kind of DDs I'm going to ask, what kind of data I should be gathering for the station, and only ask this. Please don't overdo it because you feel you know all of this. Don't keep asking unnecessary questions. Then social history, sexual history. If you feel it's an infectious disease case where it's a sexually transmitted disease, again, you can go and very brief sexual history. You can ask about their recent sexual history. Are they sexually active? Do they follow safe sexual procedures, or are they using any sex toys? So all of this is fine when you have a case where there is infectious disease or a sexually transmitted disease you're suspecting, and there is a need to ask them. Again, when you ask these questions like lifestyle and sexual history, please tell the patient that. So there are some questions I have to ask you. We usually ask these to all patients, but it might be a little unconventional. So if you feel uncomfortable, you don't need to answer it. Please make sure that you're giving a disclaimer before you ask these questions. That is very, very important, especially in case of lifestyle and sexual history. Some patients who come in might get offended if you straight away ask this history without giving any disclaimer about what kind of questions you're going to ask them. And another important, very, very important thing I would say is anything else. Why I'm saying this is, there is a good chance that we feel that we have collected the data entirely, and we have got the DDs entirely, and we have got the maftosa entirely, but we'll feel that we haven't still got the diagnosis. So when you ask a patient, when you have developed a good rapport with the patient, and you ask the patient, do you have anything else to say, or were there any other symptoms? Do you feel we missed out anything during this consultation? Usually, almost all times, the patient will give you a hint. So let's say you haven't asked about a symptom, but that is a part of this diagnosis. Let's say you've asked a patient about all of ocular symptoms. If the patient is bleeding, if the patient is not able to see, how far it is, how long they have been able to see, all of the symptoms, but you still feel that you haven't gotten to a diagnosis, and you come to anything else and you ask, do you feel that we have missed anything else? And the patient says, yeah, I've had flu 6 weeks ago. And then it might look, okay, I'm dealing with an infection in the eye, or it could be conjunctivitis or ocular toxoplasmosis, and from there you can still, briefly ask some questions to come with a diagnosis. So we make sure you ask this question even though you feel you missed anything during your data gathering. Please ask them if they have anything else. That is very important. Now, coming to, so we have gathered our data, we've gathered all the past history. So whenever you give information, again, coming back to the most important chunk check, you explain the patient for 30 seconds, ask them if they have understood, and then go to the next one. Please always keep doing this. Don't give a brief explanation of 3 minutes and expect the patient to understand it. If they don't understand it, you will have to explain it again, and you lose time, and you might also lose on your IPS marks because the patient is not able to understand it. So pause after each section. Signposting is what I've talked about. So signposting basically means you give a disclaimer about some questions you want to ask, but patient might not be patient might not easily answer these questions. So that is where signposting comes in. Then you ask ICE. So again, this is a mnemonic we use when we have completed all the data gathering. ICE is basically ideas. Was there anything you thought it might be? They might have already something in their mind that this is the idea. Probably, let's say you have completed data gathering and past history, and you haven't come up with a diagnosis, and you ask the patient, was there anything you thought it might be? And the patient says, yeah, I think it might be multiple sclerosis. And you ask them, why do you think so? And they think she might have not mentioned it in family history, but she might tell, my aunt has multiple sclerosis, but I think I have multiple sclerosis. So again, you might come up with a diagnosis at this stage, and this is another useful question which helps you to come up with diagnosis. Again, concerns, what about it is worrying you in particular? So the patient might have one specific thing in that whole array of symptoms which they might be worried about, which you can address in your management part, which will make the patient happy and which will give you good marks and IPS as well. Expectations, is there anything in particular you were hoping we would do today? So patient might have the idea that they might have come for an ear infection, but they would have tested negatively for bacterial infections, and what they would expect is they would get antibiotics today. So again, when the patient has some idea like this, when you come to management, you can address that again. You can explain about what kind of infection they have and why they don't need antibiotics, and why they shouldn't be given antibiotics unnecessarily. So these three questions again, is very important to a format, very important part of the format of data gathering stations. So do you guys have any doubts up until this point? Yes, please do ask. Tarun Kumar.
Yes, there are many check stations and only 8 minutes left. Is that possible to cover all these topics?
I didn't get you. Can you come again?
Yeah, you have just dealt it in many means. It takes around 15 to 20 minutes in case history taking in case of university practicals.
Yes.
But how could we manage in 8 minutes?
So coming to it again, from the beginning only, you will keep getting idea, and all patients or actors who are there have been designed to make you complete the station in 8 minutes. So usually in most of the data gathering cases, when you complete your Socrates or 40 para, you will have a very clear diagnosis in mind. So what I've given in brief for the past history, again, ICE, is when you are not able to pick up a diagnosis after you've completed all these questions about symptoms. So once you enter a station, you will see either it's a GP clinic or A&E. So you can pick a lot of verbal and non-verbal cues even before when you start the station. And once you start the station, patient will make you feel it's an emergency or not. So from where you start till you come to clinical examination, patient will keep giving clues as to what it would be. Even if you miss it in entirety and you come to management with no idea about what diagnosis could be, patient will ask you some question which might make you think about a particular diagnosis. You can still ask the patient, sorry, I want to ask you more questions. Can I come back and ask questions and come up with a diagnosis? I know it is very hard to, complete all these within 8 minutes. So you ideally don't need to, take all of this and use it in a single station. So parts of this only will lead you to a diagnosis. I'm giving you an idea as to when you don't get a diagnosis, what and all will help you to get a diagnosis. But that doesn't mean, again, you waste all these time in data gathering alone. You go to clinical examination, you can come up with a set of differential diagnosis that for a foundation year doctor, which you are, it's still very much acceptable and you will usually pass the station. Did I make myself clear?
Yeah, thank you so much.
Okay. So the next part of your history taking is examination. Always make sure you tell this word chaperone, because all examinations in the UK is done with the chaperone. There needs to be a third party, who needs to be there when you're examining a patient. That is for legal reasons as well, but to make sure that patient is comfortable. If a patient declines the chaperone, please make sure that it comes in the notes they're taking, and please first of all insist that there needs to be a chaperone, and that is part of the examination we do. And then what you do is you explain the procedure, you tell them what and all you're going to do, and if you have to sit the patient if the patient has to be in a particular position, tell them what position they have to be in, and explain to them why you're doing this certain examination. For example, digital rectal examination for cases where you're suspecting prostate swellings. Ask them, tell them, explain to them why you're doing this examination, get their consent. Confidentiality is very important when it comes to, again, psychiatric cases and cases where it's very confidential information. Make sure that patient feels confidence that you are not going to tell that to anyone, including the family or the police. So these are all very vital parts of examination, and that's why I wrote examination with chaperone. This word needs to be ingrained in your mind whenever you talk about chaperone. Again, consent and confidentiality, these 3 C's are very important part of examination in history taking stations. Next is what kind of examinations you do. So you do a general physical examination, usually where you take your blood pressure, heart rate, breathing rate, oxygen levels, and in case of like systemic symptoms, you do systemic examinations. Or in case of orthopedics or surgery, you have particular named tests which you use, to pick up the diagnosis. You could mention that as well. Now, revealing the diagnosis. So basically, we have dealt with data gathering structure, examination of the patient, and now we have come to revealing the diagnosis. Now, make sure you reveal the diagnosis in a way you have picked words from the patient about what patient is told, and paraphrase the patient's words and put it into a diagnosis. Tell them, so based on what you've told me, excuse me, and what examination I've done, I think it might be this. So as you all know, we are not doing examination in most of the cases. We are just verbalizing, and we just have gathered data for 3 minutes. So you are not sure about the diagnosis. You're not going to give a final diagnosis. You are just telling them what it could be. So that is very important. When you reveal the diagnosis, you have to tell the patient that you are expecting it could be this based on what you've told me and what I've examined. Never give an answer where you say this is the diagnosis and I'm pretty sure about it. No, you're not. You're just gathering data for a very small amount of time and examining them for a very small amount of time. And When you have a station with a certain symptom, uh, again, have the tests you will do in your mind. Like 1 or 2 years back, whenever you verbalize that I will do these tests, usually examiners gave out all the tests they were uh, you know uh, uh, going to give you, but nowadays they withhold the tests you're not verbalizing. So make sure you have an idea about what all tests you will perform for this particular patient, and you tell that the examiner usually will give a paper where what and all examination has been done, is positive or is it negative. They'll give you all the information, and always acknowledge their concerns, address them, thank them for the cooperation. For example, you're doing a digital retrieval examination, thank the patient for allowing them to, allowing you to examine them, and thank them for their cooperation, and then chunk and check. Again, uh, explain to them what it could be, explain the condition in brief, and again, don't use very complicated medical jargons, use very, very simple terms like procedure and condition, heart attack, pain. So keep it very simple and tell them what you might do for it. So again, from the information you've given me and from the examination I've performed, I suspect that you might have a condition called so and so. Excuse me. So now coming to how do you manage it? So you've explained to the patient what it could be, you've explained the diagnosis, you've explained probably, or you've explained it, the differential diagnosis for this patient. Now you're coming to how do you manage it? So usually in case of conditions where, let's say MI patient might have a smoking history or a alcohol history or a very bad diet and exercise regime. So when you come to management, you tell them, so Mr. Harry, I feel that, in this particular case, we can do something for you and you can do something to, make your health better. Which one do you want to know? So the patient might tell, what can I do, doctor? So you tell them, so we feel that smoking could be the reason you've gotten this, and explain to them why do you think smoking is it, and ask them, do you feel you can quit smoking? Don't force anything onto the patient. You shouldn't tell the patient, I think smoking is the one causing this, so I think you should stop quitting. Patient again might feel that you're forcing something upon them, and the patient might not listen to what you're telling. Get all lifestyle modification out of patient's mouth and not the other way around. That is very important. And give a brief summary of what could have happened and what led to this and what we are going to do. So this is how you basically deal with management. So in what you can do, probably you will have a general idea about what medications you can give for that patient. So again, you don't need to remember all the medicines name you are going to give for a certain condition for a certain patient. You can simply explain them, we are going to give some medications for to reduce your increased BP. We are going to give one medication so that you don't have chest pain. We are going to give one medication so that your blood doesn't clot and you don't get further episodes of the same symptoms. That much is enough, because that is what they expect as you are a foundation year doctor. They don't expect you to remember very important drugs or anything like that. If you explain this and the patient is very happy with your explanation, that is it. So make sure you condense it into very simple terms and explain to them in that particular way. And now coming to the third one, referrals if necessary. Usually in many cases, there might be a need, for you to refer that patient urgently for a procedure, or urgently for something, or if you feel that patient might have a cancer, you might have to refer them to the oncologist. So again, there is guidelines for all these referrals about how fast you should refer the patient in every particular case. And so these are all things you have to learn, before going for the exam. There is oncology referral pathway, where you have a particular time when the patient should go to the specialist. There is a particular time when the patient should get diagnosed, and there is a particular time when the patient should start with their treatment. So all these guidelines you should learn before sitting the exam. Now, the next one is lifestyle modifications. Again, lifestyle modifications is a very tricky one, because you shouldn't be giving lifestyle modifications for patients who are having some emergency, and you are managing them with emergency measures. There you shouldn't go and talk about lifestyle management. Or so make your mind, when you come to management, about what and all you're going to deal with in management, and don't give unnecessary advice which the patient doesn't need at that particular point. Let's say a patient is going to get admitted, and you're going to admit the patient. You don't need to give lifestyle modifications. Probably if there is a station where you're coming on the last day of discharge, and you're giving a counseling for the patient, that time is a very ideal time for you to give lifestyle modification advices. Now, again, coming to safety netting, in almost all cases where you have patients coming in with simple symptoms, you have to safety net and tell them, if you have these set of symptoms, or if the symptom is getting worse despite the medications, please feel free to come back to us, or please feel free to come back to the ER, so that we can look into it more, and we can do something about it. And you can also give, in addition, I haven't mentioned here, you can also give pamphlets. So always in the ER, in all NHS, almost all NHSs, you have leaflets for all the common conditions they encounter in the ER, and you have leaflets in the department for the common conditions they encounter in the department. So you can give them for them to read what they might be having, and help them understand the condition better. So yeah, so has everyone understood everything till now? Do you guys have any doubts till now? Okay, I'm assuming there is none. I'm moving to the next one. So how do you make a two-way conversation? So again, examiners don't like when you're repeating the same statement. Probably what all of us do is, when we go into an academy, or we are reading some PLAB2 books, we have this stock phrases for IPS, interpersonal skills. So always we ask the patient, did you follow me? Are you able to follow me? We'll be repeating the same sentence throughout the station, thinking that this is IPS, this will make the patient empathize with them. No. So if you keep using stock phrases, there's a good chance that the examiner, or the patient, or the actor who is the patient, might feel that your IPS is not adequate, and you might not be able to follow a rapport with them. So at the back of your mind, at least frame 6 or 7 sentences, which will help you have these two-way conversation with the people. So I've mentioned some of them here. So you can ask them, did I make myself clear? How does it sound? So when you're asking the patient to quit cigarettes, and you are giving them a plan about quitting cigarettes or smoking cessation, ask them, how does this plan sound? Do you think we can, modify this? Or do you think you can cut down a little and go from there? Are you able to follow me? Are you with me? Are we still together? Are you able to understand what I'm saying? Are you getting me? Are you keeping up with me? Are we still on the same page? Because a lot of angry patients, you might have a very differing opinion when you explain to them about something. So these are some of the sentences which I've picked and which I've given you for making two-way conversations with people, when you're performing a history-taking station. Now next, yeah. Now coming to pediatrics. So pediatrics stations are pretty similar to medicine, but the only difference is you're addressing a child and a parent. Usually in most history-taking stations, the parent only will be there in the station, and no children will be there. So usually when you ask them where the child is, usually they'll be in their home or just outside playing. So you have to address both of them. And usually parents of pediatric children are even more concerned and even more anxious about what their child might have. So deal with them very carefully, be very sensitive to what they are going through, empathize with them, and try to understand what their child is going through. So ask them if the child is with them. If not, ask them to bring the child at a later point in time, so that you can assess the child's vitals. So next is, what is the 4 or 5 additional things you ask in pediatrics? We call this mnemonic called bird history. So bird history is basically birth history. Birth history is if the child had any traumatic events during birth, or was it a simple vaginal delivery, or was there any instrumentation, was it a C-section? Next is immunization. So is the child immune, up to date? In some of the infectious cases you have, the mom might tell, the patient or the child has not gone through immunization, where you suspect mumps and measles. So again, coming to Red Book is something very unique to the UK, where they note down all the developmental milestones. So you have to ask, are you satisfied with the Red Book of the child? Usually the child is usually developed and they have a satisfactory Red Book. And development and diet, and is the child, do you feel the child is as developed as their peers, and is the child doing what the peers of the child are doing? And do you feel there is any difference in between the child and the peers of the child, probably in a nursery, in a play school, or in a school? So if you ask them, they might pick something in particular, and they might give you an idea about what the child might be going through. Then the 3 basic things you ask is pee, poo, and play. Is a child eating well, peeing well, pooping well, and playing well? So usually when you have these 4 things and you've asked these 4 things, and usually in most of the cases it's all fine, then usually in almost all cases there will be nothing physically wrong with the child if the child is doing all this. Now, coming to one of the very important things in pediatrics with respect to the UK, social history. So social history in the context of pediatrics means what is who is the child growing up with? Probably the mother would have brought you in, for the consult, brought the child in for the consult, but who else is at their home? So is there a grandmother? Is there a father? Is there a boyfriend? So if it is a boyfriend, is the boyfriend the biological father of the child? So you ask all these when you suspect NA, non-accidental injury, where the child might be getting abused by, the boyfriend or any other person who is not related or related to the child, and siblings. So there are stations, where mother has twins, and they feel that one child's developmental milestone is far ahead than the others. So you ask them, you compare them with the other sibling. Do you feel that there is something wrong, or something different with this sibling? And so for comparison reason, that's very important. And another reason you ask about siblings is when you have a lot of when you have a child with neurodevelopmental issue, you ask them, is it the first child or is it the second child? Did the first child have any neurodevelopmental issue, which might be the case in second child as well? Or you're dealing with syndromes like Downs, where they would have another child with Down syndrome, and now again they're having another child with Down syndrome. So yeah. So I hope you guys have understood the entire structure of medicine and pediatrics. Do you guys have any doubts at this point? Yes, Arun.
Excuse me, sir. What about the diet history?
Yeah.
Do we have to take a 24 hours diet history, or like what pattern? Can you please explain
No,
me
no,
about
no.
that?
Yeah, you can ask a very generic diet history, like, are they feeding well? Like, if it's a 1 year old, is the mother still feeding the child? And is the, child, how many times a day the child is consuming breast milk? Or if the child is, in a normal diet, is the child eating well 3 times a day? What kind of food is a child taking? That is pretty much enough. You don't need to take a 24 hours, diet. It might come into
Okay.
play where you might, suspect a Campylobacter jejuni, infection, where, the child has been taken out for food outside or something like that. Then you might need a short, diet history where the child has consumed food from outside and, has got an infection because of that. In that cases, that short diet history might be useful. Or otherwise, usually in pediatric cases, you can ask generic questions about their developmental milestones or compare them with another child of that age. And usually actors or the patient will give you necessary information. So you don't need to go into very specific details. Aarti, yes.
Okay. Okay. So
Hello.
my point of view was to
Yeah.
ask about the
Uh,
amount of calories we
so,
intake per day.
so from what we have learned till now, you don't have, we don't expect any stations to, where there is a need for you to ask calories per day. So we don't encounter stations like that. So
Okay,
usually
sir.
there is no need to ask, calories or anything in depth about diet. Probably when the child has constipation or, any abdominal symptoms, you can ask more about the diet, explore about the diet. Again, it's basically very generic. What kind of diet is the child taking? Is the child not taking any
Okay.
fiber rich food, something like that? That is it. So you don't need to go in
Okay, sir.
depth because you might.
Superficial history is enough.
Yes,
Superficial
superficially it's
history
enough.
is enough.
Yeah, superficially it's enough.
Okay, sir.
Did I
Thank
make
you, sir.
myself clear?
Yes, sir.
Okay. Aarti, do you have some doubt?
Yeah, it was regarding, hello.
Yes.
It was regarding the medicine part.
Yeah.
If that patient requires any physiotherapy, if he's having a condition that requires physiotherapy, how should we advise that? And if it is, should we refer him to a physiotherapist? It goes to referral part, or we can just tell him that you need physiotherapy.
Yeah. Again, a good question. So in some cases where you feel that you need physiotherapy, usually you can refer them. It goes through a referral pathway only, and usually there is a, in-house, in every hospital there is a separate physiotherapy department. So you can tell the patient that we are suspecting, musculoskeletal pain, and you might just need physiotherapy, and I'll give you a referral to a physiotherapy within a certain amount of time, and you can go to them and you can tell them, once you finished your physiotherapy, if you still feel that this pain is not going through, then you come back to us. We can investigate it further and find out if there is something else that is wrong. So to answer your question, yes, it's a referral pathway, and you refer to them to the hospital physiotherapy team, with details of the patient, and they will take over. Did I make myself clear?
Yes, thank you, sir.
Yeah. So we have our first mock question. So I want to volunteer, who is ready to perform this station. So who is interested? Please come on. Nobody's interested. I'll have to pick names. So Tarun, are you willing to volunteer?
Sir, it was my first class
Yes.
on PLAB, sir, so
Is
I am feeling quite difficult to attend. Can you please explain, sir?
No, that's okay. So no, it's fine if you make mistakes and if you ask the wrong questions, because this is the time where you can learn from all your mistakes and unlearn from it. In the exam, you can't. So, is there anyone else who's willing to do it? Aarti? Yeah. So,
Hello.
yeah. Hello.
Yes, sir.
So, can you perform the station?
Yes, sir. I'll try. Okay, my best.
Okay. So I'll start the timer, and after 1.5 minutes, we will start. The station. Okay.
Yes,
Begin.
sure. It is 8 minutes, right?
Yeah, it's 8 minutes. Enter the room. Yeah, you can start.
Good morning.
Go on.
Sorry. Good evening. This is Dr. Aarti, and
Yes.
I'll be attending you today. May I
Yeah.
know your name?
I'm Harry, doctor.
Yes, Harry. May I know what is your concern today?
Doctor, so I've been having this back pain since yesterday evening, and that's bothering me so much.
Um, that is bad, Harry. I'm so sorry for that trouble. And may I know your age?
Doctor, I'm 55 years old.
Yes, Harry. Can you tell me more about your pain?
So, doctor, I was feeling absolutely fine till yesterday evening, and yesterday evening suddenly I've got this very, massive back pain, and it's been getting worse, for the past 1 day. Till now, it's been getting only worse, doctor.
Okay. Harry, can you tell me if the pain? Can you tell me score your pain from the scale of 1 to 10?
Doctor, I would say it's about 7.
Okay, that must be very painful, and
Yes.
I can arrange some pain medications for that if you're okay with that.
Oh, thank you, doctor.
Yes, is there any specific pain medications that you're allergic to that you know of?
No, doctor, nothing. I'm not allergic to
Okay,
anything.
okay then. Yes, and about your pain, do you think your pain increases when you walk or when you lie down?
No, doctor, nothing like that.
So, according to what you say, your pain is stable, and whether you walk or you lie down, it's all the same.
It doesn't make any difference, doctor. It's just been getting worse. That's it.
Yes. Did you take any over-the-counter medications for that?
I just took a paracetamol, doctor, but it didn't help at all.
Okay. Okay. Is this the first time that is happening to you?
Yes, doctor, it is the first time it's been happening.
Okay. Harry, is there anything that you want to tell me regarding regarding anything that you did before this pain has started? Like, did you lift anything heavy, or were you driving
No,
somewhere to
doctor.
a long distance?
No, doctor. I was just simply sitting in my, armchair, and I was just going through something in the internet. Nothing. I was just sitting there. Yeah.
Oh, okay, Harry. So you did not fall down also?
No, doctor.
Okay, Harry. Thank you so much. You're doing very well. Just a few more questions. Don't be
No problem.
alarmed.
No problem.
Is there any other health conditions that you know that you are diagnosed with?
Nothing as of now, doctor.
Are you on any regular medications, or do you take any frequent over-the-counter medications?
No, doctor. I don't take any medications.
Okay, Harry. So I'm going to ask some personal questions. Please don't be if anything, if you feel uncomfortable about it, you can choose not to answer.
No problem, doctor.
Yes. What do you work as, Harry?
Doctor, I was working as a plumber for a very long time. Now that my son and daughter are working, I'm kind of retired, doctor.
Okay. Okay. So anything that is concerned.
I just
Okay.
want this pain to stop, doctor. It's been, very bad, and I just want this pain to stop. That is the only reason I'm
I,
here.
I'm very, that is very unfortunate. And don't worry, Harry, we'll give you the medications and it will really help you. You
Yes,
don't
doctor.
have to worry about it. We'll stop, we'll take actions regarding that.
Yes, doctor.
Okay. So a few more questions.
Yes,
Um,
doctor.
yes, are you living alone, Harry?
My wife is there with me, doctor.
Okay. So any of your family members have such complaints recently?
No, doctor.
Okay, so you don't have any fever since in the past week or anything?
No, doctor.
Okay, you have any other complaints regarding along with this pain?
Doctor, I feel like some kind of pulse, that's like beating in my stomach, and I find it very weird. Should I be concerned, doctor?
Um, we will do investigations regarding that, and we'll have examinations regarding that.
Okay.
So before confirming, we don't have to jump into conclusions. And I do you remember taking any hypertension tablets, Harry?
No, doctor, I'm not taking any tablets.
Okay, so where exactly do you feel this pulsation happening, Harry?
Doctor, I'm like in the center of my tummy.
Okay,
Yeah.
okay, Harry. I think what you have is kind of an emergency situation,
Okay,
and don't be
doctor.
alarmed. We have
Okay.
experts to handle your current situation. You can just sit back, and and just cooperate for some more minutes, and
Okay.
I'll be handing you over to a specialist. It
Okay,
seems
doctor.
like a bit of like bit of a condition that we should be concerned about.
What do you think it is, doctor?
Um, I think it is an aortic dissection, abdominal aortic dissection,
Okay.
or
What
it
is
can
that,
be an
doctor?
aneurysm as well. It can be an
Okay.
aneurysm as well.
Okay, doctor.
So
What?
we should confirm this. Before
Okay.
that, we will be running some tests and some investigations will go on, and
Oh,
by the vascular department.
okay.
So you don't have to be worried about it because aneurysms and dissections are pretty serious. But still, as we have uh, all the senior consultants here, so you don't
Yes.
have to worry much about it. We'll guide you through this, and you don't have to worry very much about it.
Okay. Okay, doctor.
Yes.
Is there anything else, doctor?
Um, Yes, is there anything else that you are concerned about? And we'll
No,
give you
doctor.
medications about your pain. Your pain will be settled, and
Okay.
after that, the investigations and the procedures will go on.
Okay.
So you don't have to worry about it. And we always will be with you. If there is any concern that happens, immediately you can report to one of us who's around you, and we'll take care
On
about
the
it.
next station.
Okay. Okay. Time's up.
Yes.
So I would say it's a very good first attempt, and your IPS was pretty good, and you have missed some points here and there, but that's
Yes.
okay. So when is your exam? PLAB 2?
I actually attempted my PLAB 1 when I was doing my house surgeon, and
Okay.
I didn't prepare well, so I flunked it. And
Okay,
I'm
that's okay.
attempting it in PLAB in February 15th again.
Oh, okay, that's okay. So it's a very good attempt for the first time. So like you came pretty good with the diagnosis. Well, yes, it is an abdominal aortic aneurysm station. So in this particular station, and this is now a general question I'll ask everyone. When a patient is coming with a back pain, what are the DDs you're considering? I want everyone to answer.
Might be associated with the renal conditions.
Correct. Anything else? So a patient is coming to A&E with back pain. What and all conditions are you expecting it could be?
Muscle injury, maybe.
I didn't get you.
Muscle injury or something like that.
Yes, yes. It could be musculoskeletal. Anything else?
Why can't be
Spinal meds.
osteomyelitis?
Maybe disc hernia,
Osteomyelitis. Okay.
Can it be a spinal
herniation,
meds?
probably.
Yes, it could be. Anything else?
Abdominal aorta aneurysm, maybe. Yeah.
Yes, it could be.
Cauda
So
equina?
anything else?
Cauda equina?
Yes. Yes. Oh yeah, I think you all got pretty good idea about what you're dealing with. Now I'll give an explanation about what and all you could be dealing with. So when a patient comes with a certain symptom like this to the A&E, so again in these type of stations, setting is very important. A patient who's coming to GP clinic with the same back pain might have a very mild version of it, or there might not. You usually assume it's not a very emergency thing there, that they're waiting in the GP clinic to come and meet you, for a back pain. And when it comes to A&E, you're usually suspecting it could be an emergency, and that is why the patient has come to ER. So coming to this particular case, back pain, what and all it could be. So first we will go into what and all emergency conditions it could be. So you want to first rule out all the emergency conditions in your DD so that you feel that this is a patient which could be dealt with slowly, and according to that you can come with a management plan. So in case of back pains, the two biggest emergencies you're dealing with is aortic abdominal aneurysm and cauda equina. So like in this case, when you're suspecting AAA, what usually is the case is patient will have back pain, tummy pain, feeling of pulsations in the tummy for a long time, and usually if the aneurysm bursts and there is dizziness and there is bleeding, the patient could have dizziness, the patient could feel fainting, and the patient can have heart racing, tachycardia. These are all acute symptoms where a patient with AAA might have, which you should rule out as a part of data when you gather data. Again, coming to the second emergency, excuse me, that is cauda equina. So in case of cauda equina, you might have bowel and bladder incontinence, you might have numbness, you might have weakness in the legs, You might have saddle anesthesia, that is around the back passage, that is your anus. You might have numbness. So again, you have to rule at least two of these questions when you're gathering data, to make sure that you are not dealing with an emergency for a person coming with back pain. Now, coming to the second level of disease conditions you might be dealing with. Now, coming to cancer primaries and secondaries. So you have to ask, did the patient have any loss of weight over a particular period of time? And you can ask urinary symptoms, increased urination, dribbling, poor stream, or hematuria in case of prostate. You can ask renal cancer symptoms, groin pain, groin to groin pain, hematuria, or if the patient has any other symptoms of cancer, you can try to rule it out. The next one there is multiple myeloma. Again, the patient might have weight loss, a persistent pain in the bones, usually in the back, tiredness, weakness, shortness of breath, and hypercalcemia symptoms, bleeding, bruising. Then TB spine is another TD you're looking at, night sweats, weight loss, hemoptysis. Then you have pancreatitis, where pain could be radiating. So when you ask in Socrates about radiating pain, the patient might tell pain is radiating from abdomen to the back, and the patient might also have a pretty good alcoholic history. And then there is IVDP, intervertebral disc prolapse and sciatica, where sudden onset of pain, back pain while lifting heavy weights is there. Aarti asked the question, was I doing anything when I was, when this pain started? And that is another important question. What was the patient doing when the particular symptom started? The patient was absolutely fine. Did the patient fall somewhere, have a traumatic injury? Was he doing something when this happened? Which will again give you a very good clue to go about the station. So when the patient straight away tells you he was lifting weights, you can rule in only to IVDP, intervertebral disc prolapse and sciatica, and you can only ask those questions and complete the station with a pretty good management. So again, now I've discussed all the DDs. You might come up with a question like, how can I, ask questions about all these DDs in the 3 minutes? You don't need to. So that is why following the structure is very important. So when you complete Socrates or when you complete 40 para, you will get a very good idea about what questions you will have to ask for DDs to rule out or rule in. From my experience, I would try to rule in rather than rule out. Come up with questions where you feel that this is the disease. Ask the symptoms about that condition so that you can rule in and confirm that it could be the diagnosis. Now, coming to the last one, which is in some cases, it is musculoskeletal pain, where you can just, give them painkillers, where they could have gotten it because they injured, they fell down, they injured, it's a sports injury or a traffic, RTA or something like that. It could be anything of this. So, yeah. Did I give you a brief idea about the station? Yes, Tracy. Okay, so we have another station, which two more stations which are pretty similar. So I want another volunteer who will perform the next station. This is the next station. So who wants to perform it? Raja, yes. I'm glad we have good volunteers. Yes, so I will give you 1.5 minutes where you can, read the station, and then we can start. Okay. Yeah.
Okay, sir.
Yeah.
Shall we start, sir?
Yeah, you can start.
Okay. Good morning, sir. I'm Dr. Raja, and I will be your treating doctor for today. So, before we move further, shall we confirm with your name and your date of birth?
So, hi, doctor. I'm Samson. I am 35 years old.
Okay, Samson, tell me what has brought you here today?
Doctor, so I've been having this back pain. So it's been quite some time. I've been having this back pain, and that's why I've come to
Oh,
meet you.
oh, Samson, I'm really sorry to hear that. Are you okay now, or should I administer you some painkiller?
No, doctor, I'm fine now.
Okay, so is it okay if we have some little discussion so that I can see how I can help you?
Yeah,
Will that be
doctor.
fine?
Yeah, doctor, no problem.
Okay, thank you. Thank you. So, can can you be more specific about this pain? Like exactly where you feel this pain?
Doctor, it's in my entire back, doctor. So,
Okay,
like, I can't like describe any specific point. So, it probably in the middle of my back. It's more concentrated.
okay. So, have you ever have this pain before, previously?
Yes, doctor. I've been having this pain for about 6 months now, but yesterday it has gotten worse very badly.
Okay. So, what were you doing while this pain got worse?
Nothing, doctor. I was just sitting simply. I wasn't doing anything.
Okay. Did you take any pain medication at the time?
Doctor, like once in a while I take paracetamol, but lately it has not been helping me, doctor.
Okay, okay, I get it. Sorry, it must be really bothersome. So,
Yes.
you said that you have taken some pain medication. Have you ever had a consultation for this pain in the past 6 months?
Yes, doctor. I went to the ER some time back, and they told if my pain is very bad, you can take a paracetamol once in a while. So I'm taking
Okay,
paracetamol when it's unbearable only.
okay. Did they do any specific investigation or what did they say about this pain? Did they explain what it might have caused it?
No, doctor. They told it's a simple, muscle pain, and you don't need to be bothered about it.
Okay, okay. So, does the pain, spread to some part like your back or your shoulders?
Doctor, like, I wouldn't say that very exactly. So it's mostly in my middle part and lower back, and it
Okay,
used it at the beginning. It started very slowly, and it's been getting
okay.
worse over this, past 6 months. Yeah.
Yeah, I do get it. It must be really difficult. So,
Yes.
I know that having a pain for 6 months must be really difficult. So, how have you been coping up with your day-to-day activity and your work? What about your work? What do you do for living?
Doctor, I am a clerk in one of an
Mhm.
IT company. So yes, it has been bothering me, but usually the pain is worse when I wake up, and towards the evening it gets far better. So
Mhm.
I kind of try to manage it, you know.
Okay, okay. So, I'm really thank you so much for disclosing this information with me.
Yes, yes,
But don't be alarmed. I'm
yes.
about to ask few more questions. Will that be okay?
Yeah, doctor, that's okay.
Okay. Thank you. Thank you, Samson.
Yeah.
So, tell me, do you feel any numbness or some kind of burning sensation over your back passage? Or
No,
is there any change in character in your stool? Any difficulty in
no, doctor.
passing stools?
No, doctor.
Okay. Okay. Thank you. Mm, so, tell me about your appetite. Was this good as used to be?
Yes, doctor. There's no problem with my diet. Like, I'm eating perfectly fine.
Okay. Okay. Is there any tummy pain?
No, doctor, not really. It's just the back pain.
Okay. Okay. So, do you have any allergies to particular type of medications?
No, doctor, not that I know of.
Okay. Do you have any family problem that you think might be important to tell it to me?
Not, my mom used to have some kind of body pain all the time, but then
Okay.
we never took any medications for it. I think that is pretty much it.
Okay. Okay. Thank you, Samson. So, is it okay if I ask some questions about your personal life?
No problem, doctor.
Okay. Tell me, do you smoke?
At times, doctor, socially, not regularly.
Okay. What about drinking?
Again, very socially, doctor.
2 minutes remaining.
Okay. So, tell me, Samson, what do you think this pain might be? Do you have any idea what it could be?
No, doctor. Even I don't have any idea. The problem is, I want this to stop. It's been, getting worse and worse lately, and I can't do anything. Even with pain medications, it's not coming down. I just want it to stop.
Okay, I can see that you're really concerned about this pain, and I think you're here for pain relief. Is that right?
Yes, doctor. Basically, I want this pain to stop.
Okay, okay, fine. So before going into that, I would like to do some basic examination. Will that be fine?
Yes, doctor. No problem.
Okay, okay, Samson. Have done with my examination, and it seems that all your vitals are stable. And other than that, I don't think anything. So I think it is better to involve my seniors in your case so that they might come up with some better diagnosis. At this point, I think you could have some muscular system pain or
Okay.
some kind of other thing, but which I'm not sure. So I think it is better to involve my senior. Will that be fine?
Yeah, no problem, doctor.
Okay. So in the meantime, I would like to administer some pain relieving medication for you for now.
Thank you, doctor.
So shall we? Okay. Thank you, Samson.
Okay.
Move on to the next station.
Yeah. So, all in all, good performance. But what you could have done is, cut short your history a little bit more, and come to the management a little bit early. That would, help. So make sure you're compartmentalized, and always make sure that when you hear the 2-minute bell, you can cut short whatever you're talking and come to management. Yeah, that's very important because you have that 8 minute and you want to complete all the domains in 8 minutes. So yeah. So coming to the station, what do you guys think it could be? What is the diagnosis? I gave a very particular clue during the station about what it could be. So what do you guys think the station could be?
Rheumatoid arthritis.
It could be rheumatoid arthritis.
Pretty close. It's ankylosing spondylitis.
Okay.
So usually, like mother has a rheumatology kind of history. Patient has pain which is worse in the morning, which is getting worse in the like better in the evening. If you asked, the question, how was the pain in weekends? I would have said weekends pain are worse because I'm not working. So whenever I'm working, pain reduces, and
Yeah.
I'm not working,
So that's
pain
why I thought of, but I didn't confirm. I'm not
Yeah,
sure
that's
about
okay.
that. So
That's okay. That's okay. And usually, you forgot to ask, is there anything else? So usually in ankylosing spondylitis, that is the only case where patient tells you, I have stiffness in the back. I can't move properly my back, And and in examination, specific to AS is modified Schrober test. So that is what you should tell in, you should ideally ask for in your.
actually, I didn't know. I should say about specific text because usually I thought that you give me some other examination finding. So I didn't want to create the examination finding.
Okay. Yeah. So back one at least 1 year back, when you asked, very generic, you tell them, I've examined them, I'll do a musculoskeletal examination. Is there any findings? The examiner usually shows all the findings. What not is positive, what not is negative. But recently what they've done is, unless you don't ask the specific test, they don't show you. So they have compartmentalized it in a way that they don't want the candidate to know the answer unless they've asked for it. So you have to ask specific tests if you want answers for the specific tests. Again, in back pain in DDs, usually you can ask mainly these two tests are straight leg raising tests and modified Schrober test. So these are the two tests we ask for. So you have to ask these specific tests. And again, when you tell that we will investigate, you shouldn't tell very generically we will investigate. You should tell what investigations are you going to do. In the first station, it was we are going to do an ultrasound, and we are going to find the size of the aneurysm, to see if we are going. It is a medical management or a surgical management. And now in this case, again, you have to do an X-ray and see, what is happening with the spine, and you have to take calcium levels, vitamin D levels. Be very specific, and that helps you, get more scores over someone who is having a very generic verbal explanation about management and investigations. Yeah.
Okay.
Did I make myself clear?
Yeah.
Yeah. So is there any other doubts till now?
Hello?
No? Okay. I have one more station for, back pain. And does anyone want to do it? Okay, Arjun. Arjun, you want to do the station? Arjun? You've raised your hand. You have a doubt? Okay, Aarti, you have a doubt?
Yeah, I have a doubt.
Yeah. Tell me. Yeah.
So
Yeah. Yes. Tell me.
yes, sir. In
What
my
is the doubt here?
in the aneurysm case, do
Yeah.
you think that I should have asked for an examination?
Yeah. You
In my
should.
case, in my aneurysm
Yeah, you
case, do
should.
you think
Yeah,
that
you're audible. You should ask for an exam. Yeah, you should ask for an examination. Again,
okay, when you
let's
said
make
about
sure you.
the pulsation,
Yeah, you should have asked for general examination, abdominal examination, and you should have asked. Okay, there is you should possibly see the patient will not simply tell you that they have pulsations in their tummy. Usually, they do have it. So when you do that particular examination, you can acknowledge the symptom for the patient. That is very important. So you can tell, yes, I could feel a pulsation. So I understand that that's been bothering you. So it's a brownie point for IPS. If you acknowledge that the symptom they're suffering from is actually there, because patient will be relieved. Patient will be thinking they're thinking something, or it's very weird or something like that. So when you actually perform the examination and acknowledge it, it's good. Did I make myself clear?
sir, but I don't really understand how to actually enact it on the day of my examination.
No, so you tell them. Thank you for answering all my questions very patiently. So, Mr. Sampson, is it all right if I examine you with the help of a chaperone? So initially, I'll be taking your vitals like blood pressure, respiratory rate, breathing rate, heart rate, and oxygen saturation levels. And then I'll have to do an abdominal examination to feel for the pulse you think that you've been noticing. Is that all right? So if you ask that, usually patients go, yeah, the doctor, that's all right. So then tell them, okay, I've performed the examination. Thank you, Samson, for allowing me to examine you. Now, do you have any idea what it could be? What concerns do you have? do you have any expectations, and then you can move to management. Again, a lot of us are very anxious during the whole when we are performing the station. ICE is a very important and good tool for you to fill that gaps. When you feel that you're stuck, you can ask them, what do you think you might have? Or you can ask them, what expectations did you come to the clinic today with? Or did we fulfill your expectations, or do you have anything else? Do you have any other concerns? All of that can be used as a filler when you are doing data gathering as well. It's very important. So did I make myself clear? Did I explain to you how you ask for examination?
Yes, sir. Yes, sir. That was clear. Thank you so much.
Do you have any other doubts?
Not at the moment, sir.
Okay, then I think so. The next question is, John.
Sir, can I try this?
Yeah. You want to try this? Okay.
If someone is trying?
No one else is trying. You can try. I'll give you 1.5 minutes for you to read the question again, and then we can start performing. Okay.
Sir, can I proceed?
Yeah, you can. Enter the room. Yes, start.
Good morning, sir. Sorry, good evening, sir. I am Dr. Jovita. Today, I will be the one in charge of doing this examination. Do I have your consent?
Yeah, no problem.
Okay, let me assure that whatever I receive for the examination, it will be very much confidential, and I will not leak any of your personal data to anyone unless it is for your diagnosis.
Okay.
Thank you, sir. Let me ask for some of your identifying data. May I know your name?
I'm William, doctor.
William. Okay, may I know your age?
I'm 25 years.
25 years old?
Yes.
Okay, thank you. May I know where do you live?
Doctor, I live very close by, Doctor, in Manchester.
Okay. May I know what's your occupation?
Doctor, I'm a university student.
Okay, very good. May I know your weight?
Excuse me, doctor?
Your weight, body weight.
My body weight, doctor, I would say approximately 60 kgs since I last know.
Okay, thank you so much for your information. If you don't mind, can I ask you, are you married or single?
No, doctor, I'm not married.
Okay, thank you for all the information, sir.
Yeah.
May I know what made you to come here today?
Doctor, I've had this back pain since yesterday evening, and it's hasn't come down per se, so that is why I'm here.
Oh, I'm so sorry to hear that. Is it on and off or continuously?
Doctor, it's continuous, it's not stopped till now.
Oh my God. It would have bothered you very much, right? It would have bothered your studies and all, right?
It has been bothering me since yesterday, doctor.
Oh, I'm so sorry for you. Okay. Can you tell me the location? Is it above your umbilical or below? Sorry, it is uh, like lower back or upper back?
A lower back, doctor.
Okay. Can you tell me, does your pain radiate to your lower limbs or your upper limb?
No, doctor, nothing like that.
Okay. Is your pain, can you define your pain? Is it pinpoint or blunt or sharp or penetrating?
Nothing like that, doctor. It's like it's throughout my lower back,
Oh,
Yeah.
okay. Okay, can you tell me you have any associated symptoms like diarrhea, dysentery, or vomiting along with the pain?
No, doctor, nothing like that.
Can you tell me what and all the factors which make you feel better, like resting?
Mm, Resting has made me feel better, doctor, and I took a paracetamol, so that has helped me a little bit.
Okay, can you tell me the dosage of your paracetamol?
Think I got it over the counter, doctor. I am not sure about the dosage. They just gave me paracetamol.
Okay, how many times you took paracetamol?
I took one yesterday night and one today morning, doctor.
Okay, okay. Does it give you any relief?
Little bit, doctor.
Okay. Okay, can you rate me your pain scale between 1 to 10, among which 1 is very mild and 10 is severe?
Doctor, about 5.
Okay, 5. Okay. Okay, can you tell me which factors made your pain so worse? Like lifting some objects or doing any heavy exercise like that?
Nothing like that, doctor. Since yesterday, when the pain started, I haven't done anything like that.
Okay, before your pain started, did you went to gym or did you perform any strenuous exercise?
I was playing football, doctor.
Okay, was it for long duration, your football match?
Yes, doctor. It was for 2-3 hours.
Okay. Um, it may be because of that. Did you lift any heavy weight or something?
No, doctor.
Okay. Okay. As I can see, it's maybe because of your football performance yesterday, which is it normal to perform 3 hours whenever you perform?
Yes, doctor. Like usually, I play like 2-3 days a week
And
football.
it's
So
3 hours a
yes,
day?
yeah, it's 2-3 hours a
Okay.
day.
Okay. Are you sleeping? What's your sleep cycle? How many hours
Doctor, I sleep what 6-7 hours.
every day?
Yes.
Okay. Do you have any allergies to medications or food?
No, doctor.
Okay. Okay. Let me refer to my senior doctor, and I will just tell your information to my senior doctor, and I will make sure that he will never disclose to anyone. And whatever you have told me are very confidential. And thank you so much for the information.
2 minutes remaining.
I will help you to get better. Thank you
Okay,
for your
doctor.
cooperation. Do you have
Yeah.
any concerns or clarifications?
No, doctor. I just want this pain to come down. Do you have any idea what it could be, doctor?
Actually, I think is you have any problem doing urinating?
No, doctor. No, doctor.
Okay, I think maybe because of a prolonged football match. But I will make sure I will refer to my senior doctor.
Okay.
Thank you.
Okay. Thank you.
Move on to the next station.
Good attempt, doctor. So you don't need to talk about confidentiality at the beginning only. So once you come to your examination part only, if you feel you're doing an examination which is going to be very uncomfortable for the patient, you need to disclose confidentiality. And if you're dealing with patients in psychiatry where they're disclosing information where uh, it's very intimate to them and they would not ideally disclose it to others, that is where confidentiality plays a bigger role. I understand your point, of making sure the patient is fine talking to you and about confidentiality, but you don't need to repeat it again. And for the first initial part, just the name and age would be fine. So you don't need to ask, about marital status and all. The examiner will think it's unnecessary information for a patient who has come with back pain. So just ask the name and age and come to the symptoms and ask the symptoms. Otherwise, very good IPS. So do you guys, what do you guys think the diagnosis is for this patient? Sprain, okay. Aarti has raised her hand. Yes, Aarti?
It can be a disc prolapse because he's young and he's been playing football.
Yeah, could be, but she asked about urinary symptoms and all, and there were none. So what else could it be? Sprain is pretty close. So anybody else has any idea? Okay, so this is a simple case of musculoskeletal pain where you don't have a particular diagnosis. Patient, you've ruled out all the emergency causes, you've ruled out all the simple causes, and you don't have anything that is significant. That is when you come to a conclusion where the patient just has musculoskeletal pain. And in these cases, like previously you asked for physiotherapy, this is the case where you refer them to physiotherapy, give them mild NSAIDs and painkillers, and send them back. You don't need to do any significant investigations because your tests like Schober and straight leg rising test will all be negative. Probably the patient might have some kind of a little bit of tenderness over the spinal region. That is pretty much what the patient will come up with. So these are the cases where you don't have a definitive diagnosis. You come up with a management plan of how you're going to manage the symptom, and you explain to them about red flag safety netting, and that is pretty much it. So you will be done. And so these are the stations where examiners are looking at you, thinking, how will you manage a situation where you don't have a diagnosis as a foundation year doctor, who is it? The first line of contact for the patient. You might not have essentially back pain. You might have a case where there is nasal bleeding with no diagnosis, or you might have a case where patient has hematuria with no diagnosis. Like, you might think about all the DDs, you would have exhausted all the questions, and patient would tell no for everything. How do you deal with these kind of patients? So that is why I put this question, to see, how do you deal a patient who only has symptom, there's no diagnosis. So that is very important. Now, moving to the first mock question for pediatrics. Who wants to attempt this? Anyone? The station says plan initial management of the examiner also have findings of blood tests or X-ray. Yes. So when you have data gathering stations and you ask all these, investigations, the examiner will give you all the findings. When you tell them there is X-ray, like ankylosing spondylitis, you will have specific findings. They might not show you the X-ray, they might give you the findings as such only. So if you ask for the investigation you want, you will get an answer. If that is the station and that is the diagnosis, you will get it. So Pracy raised her hand. So do you have any doubt?
No, I don't have any doubts. I thought I'll give a try with the next model.
Yeah, you can try the next station. Like, I will put a timer. Just give me a minute. You want to start, or you need 1.5 minutes?
Yeah, I think I'll start.
Okay. Yeah, you can start.
Enter the room.
Good morning, ma'am. This is Dr. Praislin. I'll be the attending GP for today. So, can I confirm your name and your date of birth?
And Doctor, I'm Sarah Jones.
Okay. All right. Okay. So, can I know what brought you here?
Doctor, I'm concerned about my son, Jason. That is why I came to the clinic today.
Okay. So, how old is Jason, if I may know?
Doctor, Jason is 3 years old.
All right. So, what is your concern? Like, what is your child's concern?
So, doctor, he's been behaving a little differently in his nursery. So his, I got this news from his nursery. So I'm a little bit concerned about that, doctor.
Okay, I'm so sorry to hear about that. Okay, so since when is he having all these troubles?
Doctor, the nursery told that they've been noting these, for the past 6 months.
Yeah. All right. Can you tell me more about his concern? Like,
Yeah, doctor. So basically, he goes to the nursery, but he is not interacting with the other children, or he's not playing with them. He is just alone by himself. He doesn't talk to anyone. I find it a little bit weird, or you could say that, for a 3-year-old to not be talking with other children or playing with them, and that is making me very worrisome.
okay, I'm so sorry. I get it. And can I know about his birth history? Like, was he delivered by normal vaginal delivery, or was it a cesarean?
No, doctor, it was a normal vaginal delivery.
All right. Can I ask you a few more questions if that's okay with you?
No problem.
Yeah. So can I know about his immunization status? Like, has he got all the vaccines so far up
Yes,
to date?
doctor. He is up to date with his vaccines.
So can you tell me more about his diet history? Like, is he?
He is eating well, doctor. He is eating well. He is pooping well. He's peeing well. There's no issues there. He's absolutely fine. Yeah.
All right. So does he have any siblings, and are they all well? Or do they...
No, doctor. He's my first child.
All right. Okay. All right. So does he have any symptoms like headache?
No, doctor.
Blurring of vision, seizure?
No.
So he just has just the developmental milestone delay, right? Like, I mean.
Is that a delay, doctor?
I'm sorry. I'm sorry, actually.
That's okay, doctor.
Okay. All right. So I'll actually discuss about this with my seniors, but I feel like okay. I'm sorry. I'm sorry. I think.
No problem. Like, you want to complete the session?
No, I think I'm done. Yeah.
Okay. So what do you think this case might be?
A developmental disorder, right? Delay.
Okay. And anything in particular?
Move on to the next station. Unitas Multi-Speciality Hospital treatment for
any particular condition you think you might be dealing with in a 3-year-old who's not interacting?
Autism.
Yeah. So this is a case of autism spectrum disorder. So again, the common mistake people do in this station is telling the parent that it's autism. So always use the full form, autism spectrum disorder. Every child who has autism doesn't have the same symptoms, and they don't present with the same symptoms. Some are very intelligent in something and they present at a later stage, some are not. So always tell them it could be autism spectrum disorder. Now, coming to the station, it was a good attempt. Don't worry or don't get anxious. And again, when you feel that you're stuck in a station, use eyes and all other mnemonics we went through at the beginning, and that will help you, especially when a concerned mother comes to the clinic. And usually in these cases, what you ask is questions about developmental milestones for a 3-year-old. What and all milestones will a 3-year-old have? Is the child having, or has the child achieved all these milestones? Is the child able to look at the mother's eye, interact with them? Is the child cuddling with them? And like, you suspected autism, which is very good. So in case you're suspecting autism, what questions you ask? The child has repetitive behaviors, and there's the child playing with blocks in a certain way. So all of these are the questions you're going to ask. So let's assume this is an autism spectrum disorder. What are the DDs you think you are expecting in this particular station? Anyone? Does anyone have an idea about what DDs you're expecting in an autism spectrum disorder case? What might it be if not autism spectrum disorder? Yes, Aarti.
Yes, sir. It can be any sort of trauma or any
Yes, yeah, that's
abuse
right. Very good.
related.
Yes,
It
correct.
can be abuse.
Yeah, it could be abuse. So NAI, you're suspecting non-accidental injury, which is abuse, and it could be PTSD, post-traumatic stress disorder in a child. So the child, which like that is why you should go back and ask if the was the child better before the 6 months. Before 6 months, was he interacting well, playing well, and it's just stopped after that? Because there you might be suspecting a traumatic event which has changed, the child's way of behaving with strangers. So you have to rule out PTSD, you have to rule out NAI, and you have to rule out simple, physical symptoms where the child might have an ear infection, because of which the child is not able to listen to the parent or like that, or any symptoms by birth where the child has lost its hearing and all of that. You don't want to go to all of it, but you might ask at least the abuse question and the post-traumatic question, which means you've covered most part of DD for a case like autism spectrum disorder. Now coming to the diagnosis part of autism spectrum disorder, let's say you given the parent the shocking news that it could be autism spectrum disorder. Could someone explain how do you manage it, or do you refer it, or how that works? Does anyone have any idea? Okay, so if refer to specialist. Yeah, that's right, Arjun, that's right. So you refer to a multidisciplinary team in case of autism, where there are a lot of people. There's a pediatric neurologist, there is a speech therapist, there's a psychologist, psychiatrists. So autism spectrum disorder is not a condition which is diagnosed in one day. So they run these tests and developmental tests for a period of 6 months before they conclude the child has autism spectrum disorder. And then once the diagnosis is arrived at, they treat the child according to the child's need. And in this case, the child has social developmental delays, and they will try to treat that accordingly based on what the child has. So it is very different for each and every child in the spectrum. So you have to make sure that you reassure the mother that this is a very normal child with just one domain which has a developmental delay, and he will go on to become a very normal adult. And make sure that the mom is in a better mindset when you leave the station, and that is very important. Yeah, is there any doubts in pertaining to the station? Okay, coming to the last mock question, who wants to attend this? This is again a very interesting case pertaining to only pediatrics, or sometimes in case of geriatrics as well. So with this, we'll complete it. So I want one person to volunteer for this. Who is ready? Arjun, you want to try? Whoever hasn't tried can try this, or whoever has tried also can try this. Tracy. Abantika. Aarti, Raja, you guys want to try this one pediatric station? Nobody wants to try this? Okay, if nobody wants to try this, at least can you guys tell me what the station might be and how do you address the station? Anyone? Yes, Raja.
It could be non-accidental injury.
Yes, and why do you think so?
Because 4 months old boy cannot walk, or it just started to roll out.
Yeah, correct, perfect. So, who do you? What kind of history are you expecting in this? Like to be
I will
hospitalized?
ask about this. Who else living with her mother? Who else is in the house?
Yes, yes, correct, absolutely right. So you'll ask about home conditions. Is there a boyfriend? Is that the biological father? Yes, Aarti. Do you have any doubts?
Yeah, but the babies take 6 months to roll over. So
Yeah, correct. Exactly. Again, what Raja told. Correct. This is a case of NAI. So this is a case where we are dealing with an NAI. So let's say you have come up with the diagnosis of NAI, non-accidental injury, by the boyfriend or something. How do you deal with that in this case? How do you manage this case?
First, I will admit. Right away, I will admit, and I will take all
Correct.
the X-rays. I will check for any
Yes.
fractures,
Yes.
and I will
You do a
involve social
skeletal
services.
survey.
Yeah,
Yes, correct.
exactly.
Yes, yes.
After
And
that,
see,
if
yeah.
the patient is, I'm sure if the patient is all right, then I will involve social service.
Correct. Correct. Yeah. Yeah. That is pretty much the whole idea of the station. So what happens in these kind of cases is sometimes mothers of these babies get defensive that nothing of that sort could have happened, or my boyfriend wouldn't do something like this to my baby. So you will have to come up with impactful IPS where you don't like make the mother angry, but you also deal with the child in a very safe way. That is what they're looking at. You have to be a safe doctor, and the mother shouldn't get angry. So you tell them this is a part of what we do on a daily basis. We suspect it could be a non-accidental injury, but we hope it is not. We hope it could be something else. We will send the social service to your home and look at it. And if the social services have cleared you, it will be absolutely fine. And I hope that is the case in your home as well, and there is nothing wrong happening. So that you don't like throw the mother under the bus, but you also make sure the baby is absolutely safe. Yeah. So yeah, in this is how you deal with these cases. So do you guys have any doubts? Yes, Arthur. The previous case was also...
yeah,
Arthur.
is when we open up to the mother that we are going to involve the social services, should we be
Yes.
like, I'm really sorry, but I am bound to do this just for the safety of the child? Should we start it like that, or
Yeah.
we can have any other ways of opening it up to her?
So see, the mother is more concerned about the baby. Mother wants the baby to be absolutely fine. Usually in these cases, when you ask the mother how the child has gotten the swelling or how do they identify it, the mother would tell you usually he cries or she cries, daily. But today has been an incessant cry and the baby hasn't stopped crying. And that is when I opened his clothes and I, checked and I found a swelling in his arm, something like that. So you always tell the mom whatever we are doing as in regards to investigations, in regards to social service, it's all to make sure your baby is absolutely safe, and that is our number one priority. And we also hope that nothing bad has happened, at your home. And I sincerely hope nothing bad comes out of the social services report as well. But we want to make sure, and this is what we do on a daily basis. Did I make myself clear?
Yes, sir. Thank you so much.
Okay. And Apontika asked, what do you expect, to do in case of autism spectrum disorder? What and all examinations, you do for autism spectrum disorders? Yeah, and autism spectrum disorders, usually in stations which mimic PLAB2, you don't usually the parent doesn't get the child. So ideally, you tell them that when you bring in your child, we will do a thorough physical examination. We'll check for all the developmental milestones, and I'll refer him to a pediatric specialist. And because I'm suspecting this, I'll refer to them. And if the pediatric specialist doesn't find anything, then it's okay. But if he still also finds something, something bothering him, he will refer you to the multidisciplinary team. This is in case of GP. When you are in an A&E setting, there is an in-house pediatric specialist. So what you do is you ask for a pediatric referral then and there. The specialist will come and see, and they will refer them to a multidisciplinary team, an autism clinic, where they look at these children and diagnose them for 6 months, and then come to the conclusion that the child might have autism spectrum disorder. Next question: as FI2, am I expected to say I will involve senior in this case, because FI2 is not expected to handle safeguarding it? You might involve the senior if the mother is getting very defensive, or you're in a condition where you're not able to convince the mother to make the child stay there, or if you feel that it's getting out of your hand. But otherwise, you can just explain why you're doing involving social services and why you're suspecting NA. In most of the cases, mothers do, or the actors do accept what you're saying, and they are fine with it. So it shouldn't be an issue. So do you guys have any other doubts? Okay, so that comes to the conclusion. Do you guys have any doubts regarding history taking in medicine and pediatrics? Did I make you understand all the nuances in this? Do you feel is there something else we should have discussed, or do you guys have any questions or feedback? I'm free to take it. Or did you guys find this class useful?
Yeah, I think one of you can give us, because we are starting this as a trial basis. That's why we are doing it like every week. We are doing a test and trial way to see, to adapt a technique which should be useful for most of the candidates. So if one of you could give us a feedback of how you felt. And as you are all aware, we are having another like 7 or 8 sessions on every Sunday for the next 6 to 8 weeks on specific topics related to the PLAB stations. If you think you want to do it in a different way, please feel free to give a feedback. But I would request any one of you to give a feedback of how it went today. Someone has texted in the group, Sibi.
Yes. Would I get scenarios with patient deteriorates during history taking and PLAB2, like immediate BP in aortic aneurysm cases? So actors usually don't, fall down like that or anything. But in case of an aortic aneurysm scenario where, you have a patient who is getting worse, patient will give you symptoms of fainting, heart racing, and all of that, which should give you an idea about this is a management for an emergency. There are cases where the patient come with aortic aneurysm, but it's a medical management because the aneurysm is in burst, or so when you look at the ultrasound, you have the specific measurements where you do surgery where it's managed medically. So you explain the patient, this is AAA, and we'll do an ultrasound, and based on what we find in ultrasound, we'll manage. Usually in case of emergencies, they will give you symptoms where, it is emergency, where you can start a massive hemorrhagic protocol, you inform vascular surgeon, and you admit them. So it mainly depends on, your presence of mind in the station. Is the patient having an emergency? It's an emergency condition. It's going to be medically managed or surgically managed, and how do you manage it in that place? And coming to your question, usually patient will give you symptoms of deterioration, but will not deteriorate in front of you. Yeah. Yeah. So guys, do you feel like we need to add some other stations? Give any feedback if there is something wrong or anything that could be added. Please let us know. We'll try to add it and we'll make it more useful for you guys. Yes, Aarti.
Yes, sir. Thank you so much. It was actually unexpectedly very helpful. I didn't think that we will get a chance to do some of the cases. And I just think that if we get to see an ideal interaction between a candidate who is who will very sure pass that station with an examiner, if we have a such example to look up to, then we can compare ourselves to the other person. I just think that might be helpful.
No, that's a great feedback, Aarti. Thank you so much about that. I think that's a good way to go, especially when you have a mixture of crowd where people who haven't started preparing for the PLAB and who are coming from a background where they're used to taking extensive discussion, extensive case histories, which lasts for like half an hour, 45 minutes. Doing a station in 10 to 15 minutes, I think it would be ideal. So we will take this feedback very seriously. Probably from next week, we will have a candidate. Probably we can even contact one of you, or we can have interaction between me and probably whoever is the presenter, and we can do that thing, definitely. Yeah. So just to let you all know, the whole purpose of we doing this is, as you are all aware, most of the PLAB 2 candidates are traveling to UK to do a mandatory 2-week or a 3-week course. But in the era of online training and online teaching, we are aiming to provide as much as we can over online. Thereby you can plan your preparation over a period of time rather than coming to UK and prepare in that 2 weeks with an intense preparation. So we are aiming to come with a schedule where candidates who are preparing for PLAB 2 exams can start preparing and practicing at least like 6 months or 8 months even before the exams, and then probably you can come to the UK for the last 2 weeks of intense course, and then you can practice. So again, to let you all know, we have a schedule. I hope you are all there in the our Telegram group. So we have a fixed schedule we will put up again, and go through the schedule, do some homework before you come to the session, so you will know what you are speaking and what is right and what is wrong. That's what I would advise. And any kind of resources which you like, specifically if you can put up in the group, we will try our best to share those resources. And I hope we will have a very successful series of webinars. Anything, Sibi, you want to add?
No, sir. Like any kind of feedback you guys provide, like Aarti said, we can probably do this as well. So we can record these ideal candidate and examiner stations, and we can upload it on YouTube as videos as well, which might help them how you approach a station. And you guys have any negative or positive, any kind of feedback and any kind of improvements you want to do, we're always open to that, and we want to improve these sessions. And like Manikandan sir told, we want you to go to the UK probably for only, where mannequins are involved or something like that, where you have to interact with something. Otherwise, you should be very well prepared, before you go to the UK, and cut down the time of you staying in the UK with online preparation as much as possible. Please feel free, if you found this session useful, please share it to your friends, who are trying to attempt PLAB too, and we will try to help them. Not only in these cases, if you guys have any doubts about anything else, jobs or residency or anything, whatever we know, we'll try to share that information with you. And our contacts and mail is there in Telegram group. So yeah, is there anything else? If there's anything else, we can conclude the station. And if anyone wants to talk or give feedback, please do. Thank you.
I think they had put a lot of feedbacks in the chat group. It's fine. So, yes. And another thing which I want to tell is, you need to all open up. Yeah, you should feel free to ask whatever you want. It's not just for the sake of the exam, but it's very, very vital when you go up in your career. Yeah. So don't hesitate to switch on the cameras. Don't hesitate to speak up. Don't hesitate to open up. Yeah. So those things are very, very vital as you go up in your professional career. Okay, good. I think we had a wonderful 2-hour session, and thank you very much, Dr. Sibi, for your valuable time and an excellent session, giving them a brief overview. And thank you all the participants for today, and we will try to catch up next week in the same time. Thank you.
Okay. Thank you.
Sibi, can you stop this recording and transcribing, please?
Yes, sir.
Because I couldn't.